Okay. Good evening, everyone. So, we welcome you to the first multi-speciality approach to PCOS webinar, and hopefully we'll make it a face-to-face meeting soon. So, this meeting has been pioneered by three societies. One is the Endocrine Society of India, the PCOS Task Force. The second is the Obstetric and Gynecological Society of Hyderabad. And the third is the Indian Association of Dermatologists, Venerologists, and Leprologists, Telangana branch. And this is a very unique CME because we are bringing three key stakeholders in PCOS management: the obstetricians, gynecologists, the dermatologists, and the endocrinologists. And we thought we should have some consensus as to how to treat these patients and who should be managing what part, and how together we can make a difference in the life of people who have PCOS. So without further ado, I think first I will just want to introduce the chairpersons. Dr. Ramchandra Darak is the Honorary Secretary of the Telangana Society of Dermatology, Venerology, and Leprology. And Dr. Jayanti Reddy, who is the President of the Obstetric and Gynecological Society of Hyderabad. I will ask Dr. Ramchandra Darak to first introduce the panel one, where we are going to talk about a 14-year-old girl with irregular periods and hirsutism. I will just introduce the panelists first and then hand over the proceedings to Dr. Ramchandra. So the panelists for the first session are Dr. Hemant Fatale. He's a senior endocrinologist from Chhatrapati Sambhaji Nagar in Maharashtra. Dr. Tejal Lathia. She's a senior consultant endocrinologist from Apollo Hospitals in Navi Mumbai. Dr. Runa Acharya. She's the clinical director and senior consultant reproductive medicine and surgery at Medicover Fertility, Hyderabad. Dr. Madhuri Mova, laparoscopic surgeon, robotic surgeon, and fertility specialist, director of Madhuri Hospital. Dr. Rajita Damisetti, who's the founder and senior consultant of Mohana Skin and Hair Clinic in Hyderabad. And Dr. Sai Krishna K, who's a consultant dermatologist from Yashoda Hospital, Secunderabad. The moderator for the first session will be Dr. Khushbu Agarwal, who's an assistant professor in the Department of Endocrinology, Diabetes, and Metabolism in CMC Vellore. So I hand over the proceedings to Dr. Darak, sir. So you are on mute. Dr. Darak, you're on mute, sir.
Yeah. So good evening, sir. Dr. Santosh. Thanks for the good words spoken towards me. So Dr. Santosh is a treasurer of the Endocrine Society of India. So now I'll move on to the topic, today's topic. There is one panel discussion. In this panel discussion, there are two endocrinologists, two gynecologists, and two dermatologists. My colleagues dermatologists are Dr. Rajita Damisetti. She is a senior consultant dermatologist, and Dr. Sai Krishna is a senior consultant dermatologist, Hyderabad, Yashoda Hospital. So welcome all the other colleagues of endocrinology and gynecology for this panel discussion one. The panel discussion one, the moderator is Dr. Khushbu Agarwal. Dr. Khushbu is assistant professor, Department of Endocrinology, Diabetes and Metabolism, CMC Vellore. So I invite Dr. Khushbu Agarwal to take over this session of panel discussion, first panel discussion. Thank you very much.
Thank you, sir. Thank you, sir, for a kind introduction. This is a very, very interesting. This is a very, very interesting topic. And adolescent PCOS, we all have girls who come with irregular periods and hirsutism. And the interesting part about this panel is that we have all the stakeholders who are part of the discussion. So without further ado, I would like to share my screen and start the session. Are my slides visible?
Yes.
Yeah.
So, yeah. So this is a 15-year-old girl. She had menarche at around 11 years of age. Now she has come with irregular cycles and weight gains. Cycles were always irregular. She had only 3 cycles in the last 1 year. Last cycle was 4 months ago. She also has complaints of facial hair on chin and on side areas of the cheek. She has now started to develop painful cystic acne on her face and back. So on examination, she had a weight of 78 kilograms for a height of 156 centimeter with a BMI of 32.1 kilogram per meter square. She also had acanthosis grade 2. Modified FG score came out to be 12 by 36. She had multiple acne scar with few active lesions on the cheeks. She did not have any striae, galactoria or proximal myopathy. So my first question is to Dr. Hemant sir. What are the most relevant history points in examination of this young girl that can point to a secondary cause? And talk to us about the biochemical and imaging required to make the diagnosis and rule out the secondary causes.
Thank you, Dr. Khushbu. See, in an adolescent girl in a perimenarchal age group, we need to be very careful differentiation between physiology and pathology as far as menstrual history is concerned. Initially, the first year, the more than 50% cycles are annuality cycles, and cycles may remain irregular for the first 2 years post-menarcheal. So post-menarcheal cycles more than 2 years, if cycles more than 45 days, is supposed to be pathological. Having said this, if cycles more than 3 months are durations, and even the first or second is supposed to be pathological. Coming back to our case, where it is clearly says to have pathological anniversary cycles. Uh, as I said, in the initial perimenarchal age group, where the transient physiological hyperandrogenia is also known. To some extent, the acne formation and maybe mild hirsutism is also known. So we need to differentiate between these two. And the perimenarchal age group, very small time or less time is exposed to the androgen. So advanced hirsutism is unlikely. If it is there, it is pathological. So coming back to our patients, this patient has hairs at the on chin and the acne also painful cystic acne, which is suggestive of hyperandrogenism. So this patient has uh, gaining weight, anovulatory cycle, which is pathological, and hirsutism. When coming back to on examination, this patient is clearly obese, not obese, but it is morbidly obese, and with signs of acanthosis nigricans, that is insulin resistance, which is speaking of. If you look at this, the chances of developing this prediabetes to diabetes in such girls is 18 times higher than as compared to the normal age group at this of age group. And so it is important to look at the metabolic parameters of it. If you look at the hirsutism part hepatitis, the modified FNG score is 12 by 36, and let you know that the score more than 8 is supposed to be a significant score. So in this girl with a short exposure of the period, so much advanced hirsutism is definitely pathological. It cannot be only PCOD, it's something else also playing a role in it. And so for this, possibly number one, it is obesity itself. In obesity, besides the androgens which is coming from adrenal as well as ovaries, the peripheral conversion of androgens, active androgens, oxyandrogens to active androgens is very high. And so that is another contributing factors. But besides this, there is a possibility of the non-classic congenital adrenal hyperplasia, where it's many times difficult to differentiate between PCOS and non-classic CAH. But in this patient, clear cut, it is being a disproportionately high FNG score. So it is a long time exposure of the androgens. The possibility of NCCH is very high, along with the obesity part of it. So my clinical impression in this patient is a obese with long-standing exposure to androgens, uh, causing annullatory cycles to rule out non-classic congenital adrenal hyperplasia. Having said that, when you go to approach to this patient, when you go biochemical parameter of it, number one is first to document there is a hyperandrogenemia and the level of which is we should decide the action for it. And then second part of it, which is we should associate parameters, associated disorders, and thirdly, the metabolic comorbidities we should investigate for. Number one is the hyperandrogenism. We have to do the testosterone level, DHES level. The testosterone level more than 2 nanogram per ml or DS more than 700 to suggest you of the tumorous cause for the hyperandrogenemia. The red flag signs in such patients usually rapidly progressive hirsutism, the acne is of severe form, muscular body, and the temporal blandness, clitoromegaly, hypertension. These are the red flag signs with the rapid progression in months rather than years of hyperandrogenemia, which is a red flag sign, which is clear-cut suggestive of possibility of tumorous origin of androgen. Coming back to our patient is a slow progressions, so it is unlikely to be in a tumorous range. So we expect with a higher androgen levels. And for that, we should go to morning hour serum testosterone before 8 a.m. And if uh, usually preferred method is LCMC method. If it's not available, you can go for the chemiluminescence and where early morning sample is preferred. And free testosterone, which should be calculated with the help of SHBG and testosterone, and that will be helpful for the defining the hyperandrogenemia in such patients. After confirmation of the hyperandrogenemia, we should look for the associated parameters like maybe sometimes associated with subclinical hypothyroidism or hypothyroidism, and part of PCOS maybe a mild hyperprolactinemia maybe is expected in such patients. Uh, as I said, this is a possibility of NCCH is high in this case. We should go for the morning 8 before 8 a.m. 70 hydroxyprogesterone levels. If that is more than 200 nanogram per DL, the possibility becomes very high, in which case we need to go the post-SATH stimulation test. We need to give 250 micrograms synactine, and after 1 hour, we should collect blood for the 17 hydroxyprogesterone. If that level is more than 1000, it clearly confirms the diagnosis of the non-classic congenital hyperplasia. After confirmation and where we stand after this, we should look into the metabolic parameters, maybe look at the lipid profile levels, and look at the varying degree of dysglycemia. Maybe GTT is preferred, but if the patient is from outstation, taking a long time, may not come again, in which case go for random blood glucose with HbA1c by HPLC method only, which can give a clear-cut idea about the status of the dysglycemia. Those who have strong family history of diabetes, born large, they are likely to become diabetic in a peri-adolescent or post-adolescent, immediately post-adolescent, up to 25 years of age. The chances of becoming diabetes is very high. The chances of becoming diabetes in such girls are 18 times higher than the normal girls, which is a very high figure as such. Besides this, one should not forget the girl which is having hirsutism and obesity, so they have chances of depression, anxiety, so their psychological health cannot be ignored. We should address, we should inquire, we should discuss, and if required we can take the help of our psychiatrist colleague for this management of this patient. I think I have addressed everything. And say one more point: there is no clinical signs of Cushing disease as such, which is clearly mentioned this patient on examination. So that is not entertained and discussed here. I think I addressed everything.
Yeah.
Anything else?
Thank you, sir. Thank you, sir, for giving such a comprehensive answer of the importance of an endocrinologist in the management of adolescent PCOS. I don't think we could have had a better start to this to discuss all the nuances as to the rapidity of appearance of symptoms as well as the BMI and subtle clinical features which can differentiate a normal variant from an abnormal variant. It's extremely, extremely important. So going from one important branch to the second important branch, my question is to Dr. Runa Acharya. So what is oligomenorrhea in adolescents, ma'am? And how is it different from adults? And do we really need an ultrasound to make the diagnosis? And why is it a should we do it? Should we not do it? Is it of any use at all? Because I'm sure you also have had many patients who come with these ultrasound reports which show that bilateral PCOS findings is written. And then girls come and tell ki this is PCOS. So please elaborate on these questions, ma'am.
Thank you, Dr. Khushbu. And I think a very good start. Dr. Hemant sir, you have put it so beautifully. I mean, this is what the girl would have come to gynecologist first, because she's, a 14-year-old would be brought by her mother thinking that the periods are not coming. And as you said rightly, if she has attained menarche at 11, till 14 this advancement in hirsutism and all is a little unlikely in a pure PCO. So if you look at PCO, which is divided into 4 types, so the first one is all the three: the PCOM, the hyperandrogenism, the irregular cycles, and the fourth one is where there is no hyperandrogenism, the third one where the ovaries are normal, and the fourth one where the cycles are, third one where the cycles are regular. So putting all that together, so this lady could have been hyperandrogenism, irregular cycles, still not a PCOM. So this is where I think it's very important for us to first identify. So hyperandrogenic PCO is, I think, the first thing what we have to understand is it could be a non-ovarian cause. So looking at 11-year-old girls, so we know that in PCO, if you look at the HPO axis, putting adrenal, one of the important causes for PCO, putting post pill, putting inflammatory cause of PCO, putting only from the gynecological angle or a reproductive physiology, HPO axis. So our hypothalamus gonadostat is very, very sensitive till the girl starts, attaining puberty. So starting with telarchy, if she has a good secondary sexual characteristics. So looking at this girl, there was one mention on breast atrophy. So that means the telarchy has not been very great. That is one sign that is looking that it is not going in a proper pubertal development. Okay, and she has so many other signs which is fitting into, as sir said, or maybe a non-classical CAH. The gonadostat is so sensitive, it is completely suppressed. So when it starts getting, into set, it takes 2, sometimes 3 years. So if a girl comes to us without hirsutism and all these differences, we may take it little easy. So considering secondary sexual characteristics normal, she only has irregular cycles, no hirsutism, then it would have been a totally different situation, because people these days, start treating them from the day they attain menarche. We have to give them 2 to 3 years for the gonadostat to reset properly the HPO axis to start working properly. After 2 to 3 years, then we start evaluating them. The dictum of oligomenorrhea in adolescent is a very different terminology. As sir said, we would not consider that if she has 2 years, even if she has 3 to 4 periods, we may be okay if her other factors are all good. But less than 45 days cycle, and if she's having less than 8 cycles per year, then we consider them as an oligomenoric. So it could be that they have to have minimum 8 to 10 cycles. In adolescent, we can be little, relaxed with the number of cycles. But in adult women, we prefer to have 8 to 10 cycles. Less than 8 cycles, after say 3 years of menarche, this girl puts into that feature, should be evaluated with all the hormonal levels. The role of AMH, as you said, is very skeptical here, Dr. Kushbu, because it's a pre-antral follicles. Now, what happens is, if you look at the gonadostat, it is all the negative feedback. The hypothalamus starts becoming sensitive to the negative feedback. But in the reproductive cycle, we have initially a positive feedback and then the negative feedback. So this is governed by estrogen converted through the androgens. So if the androgen is accessed, there would be definitely hyperandrogenism, maybe hyperestrogenism. A negative positive feedback will totally go. They will have anovulatory cycles. And this is the PCOM. So this PCOM we have to understand. In this girl, I think definitely I would advise her ultrasound with adrenal scan and PCO. So for us as an obstetrician, gynecologist and reproductive specialist, we think we should be doing for the girls the entire abdominal scan first. So looking at all the organs, it's very important. Fatty liver would be another sign of obesity, putting it, the thyroid, the hormones, everything, the FSH, the LH ratio, the ABI, that is androgen binding index. See, all this comes into picture in this girl, and it's very important that we try to differentiate which category she is going into.
Thank you, ma'am. This is a very, very important differentiation, as though while ultrasound may not be very, very indicative of a bilateral PCOS, it can definitely give other clinical features, clinical clues as to the cause of hyperandrogenism in a girl. And now coming to the specialty that is probably the most concerning for the girl, I think she is most concerned about this. As ma'am said that the mother brings to the gynecologist, but the girl is more concerned about the hirsutism and acne. So my question is to Dr. Rajita. Ma'am, how is hirsutism assessed? And what are the main caveats for the score in Indians? And how do we differentiate the normal pubertal acne from the acne due to hyperandrogenism?
Thank you, Dr. Kushbu. It's been a pleasure listening to all the experts, and thanks, Santosh, for teaming up with IADVL Telangana. Now, hirsutism in the clinic is typically not put through the modified Ferriman-Galway score. At this point of time, modified Ferriman-Galway score with the 11 areas which are classically assessed is what is standard, but that is going to be relevant only if you're going to do some kind of an interventional trial, and that too of a systemic drug. But in the clinic, typically, we are going to look at the areas that the girl is more interested in. Typically, that would be the face. So we don't consider all the areas equal. And any score of even more, can you just go back to the previous slide, please? So any modified Ferriman-Galway score of more than 2 on the chin, which means that even if you have a cluster of 4 hairs on the chin in this age is going to be important. Whereas even if you have a few scattered hairs here and there on the upper lip might not be important. But nowadays, what is understood is that if the girl says that from the onset of menarche till the age of 15, if the hair has changed, then that itself, that is a patient reported history, patient reported outcome is important. So if my patient says that she thinks she's having hirsutism, that she thinks that she's having increased hair in a male pattern, then that is considered hirsutism these days. Now, a very important question you asked about Indians. Now, India is a huge country, and we are, I mean, as much as we like to say that we are alike, we actually are not. So if you look at the Northeast, and if you look at Sindhis on the other side of the North, the amount of hair that they have is very, very different. And there is a classic joke about how if a Chinese man has the amount of hair that a Greek woman has, and the Greek women are supposed to be very hairy, and Chinese men, like our Northeast friends, like the Indians from the Northeast part of India, they are not very hairy at all. The Far East is not very hairy. So it seems the Chinese man would rather commit suicide than live with the hair that a normal Greek woman has. So nowadays, modified Ferriman-Galway score of even 5 is considered significant in Far Eastern races. Now, do we have this kind of a study in India comparing, let's say, Sindhis versus the Northeast? No, we don't. But we borrow. And that is how we manage in our clinics. So whatever is out of proportion for that patient's family, that patient's ethnicity within the country is important. So that is the caveat I would say that's relevant for Indians. Now you can go on to the next slide, please. So how is regular acne different from hormonal acne? I will not put it as hyperandrogenic acne because it need not be just hyperandrogenism. Hyperandrogenism could be a secondary phenomenon. So now earlier it used to be said that, acne is anyway a part of teenage and it is a normal part of growing up and then you're going to grow out of it. And we now know that that is all wrong. We now know that adult acne, especially AFA, adult female acne, is much more common than teenage acne. So what are the red flags that make someone like me, a dermatologist, sit up and take notice? If the onset is at a wrong time, if it is peripubertal, if it is prepubertal, then that is going to be an alarming sign. The distribution it's called a U distribution or the mandibular distribution. That is, again, a pointer. Any acne of any grade, even a mild acne, which is not responding to the standard therapy being typically a topical that includes a retinoid with or without benzoyl peroxide, that itself is indicative of a hormonal a cause to it. So you don't always need to have a grade 4 cystic acne, which is scarring. You could have a mild acne, which is not responding. Or some patients have this acne which responds, but then it comes right back. So these are the patients who are given repeated courses of antibiotics, and we dermatologists happen to be the highest prescribers of antibiotics, and we are not proud of it. We work hard to get away from it. Any acne which is extensive, not just panfacial, but going on to the trunk. So truncal acne at any age is not normal. Severe acne at any age is not normal. Even in adolescents is not normal. Now, there are a lot of patients who explain their acne away and they say that, she's got exams. Typically this kind of a girl would be in her grade 10 or grade 9. And then they say, because of the stress she's getting. Yeah. So all of us are under stress. Who is not under stress? But then not all of us are getting acne. Not everybody in class 10 going for board exams is getting acne. So stress exacerbated acne could be one. And then premenstrual acne that just persists, that stays on even after the next cycle. So this is about the kind of acne, the morphology, the clinical appearance of acne that makes us look deeper. And then, of course, when you have some other feature of an endocrine abnormality, it could be an insulin resistance, like acanthosis nigricans or extensive DPNs, dermatosis papulosa nigra, people call them WATS, or acrocorn skin tags. Or if you have the Saha syndrome, hirsutism like this girl has, extensive acne and seborrhea, excess oiliness, or just thinning in the frontal area or thinning overall, all these could indicate excess androgen. And coexisting features of ovarian dysfunction, like has been said, abnormal menses in this age. And of course, when you have a Cushingoid habitus, those broad livid striae and the body habitus, whenever these kind of things are there, that is when we suspect hormonal aspects to acne as opposed to the regular physiological teenage acne. Now, I wanted to point out two things actually. I was hoping that we could go on to the hirsutism question later on, but I can talk about it now. So in your slide, you mentioned LH-FSH ratio, and you also mentioned a host of tests. And I would like the endocrinologist here to quickly tell us, because all these tests are expensive. So would it make any, we want to spend our patients' money wisely. And would you want to do a LH-FSH ratio in this girl at all? I would let the endocrinologists answer this. And can I come back to this?
LH-FSH ratio will not helpful in this patient at all. It's not indicated.
Thank you so much, sir. That was the answer I was looking for. But then in the presence of all you expert endocrinologists, I thought it is not right for the dermatologist to make that statement. Thank you. Now, the points here about this girl's acne is, one, she has severe acne. She's got cystic, painful acne. She's also getting scarring. Now, scarring happens not just on the skin, but on the psyche. There was a time when, it was considered normal to have acne scars. Now, in these days of social media and Instagram and constant selfies, it adds to the depression. Dr. Hemant has very rightly brought out the psychological overlay that a girl like this would have. So we would want to take very serious cognizance of the acne that this girl has. And I would want to initiate something like isotretinoin in this. And of course, there is no point we dermatologists doing anything when the root cause is not treated. So for that, we depend on people like y'all to help us out and help this patient out.
Thank you, ma'am. As Moim has nicely pointed out, the most important point over here is that hirsutism is patient's perspective more than anything else. So we have to address that before anything else comes. So if the patient feels that there is hirsutism or features of hyperandrogenism, we should take all efforts to address that, either clinically, biochemically, or dermatologically, however it is. We have to address that. That is first.
Can I make one small point here, please? So in this kind of a patient, we would definitely want the endocrinologist or the gynecologist to institute a combined oral contraceptive, not just for her cycles, but to reduce the amount of testosterone load, to increase the SHBG. We would want her to be on an anti-androgen, and we dermatologists, we are towards bicalutamide. Of course, spironolactone is anyway there, and we like to do very bespoke, very tailored kind of lifestyle monitoring. So talking about how many calories, how much protein, how many minutes of exercise, what kind of exercise, measurements not just of the BMI, but of the waist circumference, and if possible, maybe a DEXA, maybe even a body composition analyzer using the bioimpedance.
Addressing all of these questions for ma'am now is our next panelist, Dr. Tejal Latia. I have specifically asked these questions for ma'am. So, ma'am, my questions are: what is the importance of lifestyle management in these girls, and how will the counseling or behavioral therapy help benefit this lady, and will this child get a benefit from metformin therapy?
Thank you, Dr. Khushbu, and thank you for all the efforts to organize this. So like, that's important. We all know that, but be
Ma'am, your voice is breaking.
Dr. Tejal, we are not able to hear you properly.
okay. Is this better? Can I keep my video off?
Yes. And I have the unpleasant task of saying, please keep your answers to 5 minutes, because we have one more panel after this.
Yes.
Yeah.
So I will finish in 3 minutes.
Yeah.
So I just want to play the devil's advocate here and remind everybody in the group and everybody who's listening to this that women with PCOS or young girls with PCOS are told by every single healthcare professional they meet that they need to take care of their lifestyle. And it can often be deeply stigmatizing and it can lead to lifelong consequences. Khushbu, am I audible or should I keep the video off?
No, ma'am, you're audible.
Good. It's good.
Yeah. So I have had many young women who have come to me who have been told by so many healthcare professionals about how they have a bad lifestyle. A young 12, 13-year-old girl who probably doesn't even know the meaning of a bad lifestyle. And they've been told so many times by so many different healthcare professionals about their weight and the way they look that it is deeply stigmatizing. Many of them experience anxiety and depression, poor body image. Many of them later on go on to have eating disorders. So my only request to everybody listening here today is that yes, we must talk about lifestyle modifications, but in a kind way, in a sharing partnership way, not taking side with the parents and siding with the parents against the young girl, but trying to partner with her in a positive and supportive, constructive way. So that's the first point. The second point was behavioral counseling, especially in many young women who have very poor body image, very poor self-esteem, have anxiety and depression. Definitely counseling helps a lot. I do refer a lot of my young girls with PCOS to counselors. I work with an excellent counselor who is cognizant of the problems that a young girl with PCOS has, and it is extremely beneficial. I also would like to again play the devil's advocate and remind everybody here that we are not professional counselors. So often on the patient paper, we write, I counseled the patient about this and this. As doctors, we are not trained to counsel patients. We're sharing information and education, and counseling is to be done by a professional like a psychologist. The last question was about metformin. So there are two specific areas where I use metformin. One of them is if the cycle regularity is a problem, and I don't want to start an oral contraceptive pill or a hormonal medication so early for a very young 12, 13-year-old girl who is still developing her peak bone mass and her muscle mass, then I may use metformin to improve cycle regularity in absence of severe hirsutism or hyperandrogenism. And if there are metabolic alterations like an impaired fasting glucose, impaired glucose tolerance, a pre-diabetes, HbA1c, then I would use metformin. So metformin is used very sparingly in either of these situations, either for cycle regularity or for metabolic abnormalities. Thank you so much.
Thank you, ma'am, for reminding us that at the end of the day, most important person to deal is the patient before we answer any of these questions. And my question is to Dr. Madhuri Mova. Ma'am, when will you start this patient on medication, and what are your preferred medications? Would you start the patient on oral contraceptive pill? Would you start the patient on anti-androgens? Will you start the patient on withdrawal bleeding? How will you go about it?
She's a 15-year-old young girl, as already told by Tejal. Definitely, before we go ahead with any oral contraceptive pills or anti-androgens, we'll give them a complete advice about the lifestyle, the impact of lifestyle modifications on her health. That would be the first thing. But patient is also suffering from severe acne and severe obesity is also there. So we ask her dietary changes and daily physical activity changes, and eating right and working out right. In spite of that, if the hirsutism is there, we can, of course, start her on OC pills with a very mild dose, like 20 micrograms, because there is no much difference between the type of OC pills which we use. The effect is similar, even though it is a 30 microgram or a 20 microgram OC pills. So when we are going to start her on OC pills, this also helps in regularizing her periods as well, apart from hirsutism, and also helps the patient with her acne. So when we are starting her on OC pills, it is a combined oral contraceptive pill, which is the first line of management. And in the combined oral contraceptive pill, we have both the estrogen and the progesterone component. And the main mode of action of the CPs are, it will decrease the LH, because anovulation is the main mode of action. There is a decrease in the LH, and that's why the ovarian genesis of the androgens are decreased, and it increases the hormone binding hormones also, so that the free androgen levels are also decreased by these OC pills. And as I have already mentioned, no OC pill is found to be better than the other one. So once these OC pills are started, usually the effect is seen within 3 to 6 months. And because she's quite young, we will give her a break for another 3 months. We'll see how she's improving and how she is bleeding. And with OC pills, she can have a regular cycle, her acne are controlled. And you're talking mainly about the hirsutism. It has it decreases the androgen level. Basically, the treatment of hirsutism involves, like, you decrease her androgen synthesis, and decrease her free androgen circulations. Whatever little androgen is there, then it has to be excreted. And so these are all the mode of actions that we take into consideration when we are giving them the medications. So in spite of giving her of course, before giving her an oral contraceptive, a thorough counseling is given, a thorough history is taken, because we want to know whether there are absolute contraindications like thrombophlebitis, any DVT is there, any cerebrovascular diseases, cardiovascular conditions are there, severe liver disease is there, she has any breast cancer history, liver tumors. All these we have to rule out. Then only we can suggest. Of course, relative contraindications like are anyway there, like the pair has any congenital defects with her metabolic syndromes or anything like that. So in spite of oral contraceptive pills, the patient is, if there are any absolute contraindications for OC pills, or patient is not able to tolerate the OC pill, then we can consider the anti-androgens. Like spironolactone, which is you want me to go through, because very little time is there, they are telling. So I'll go for the anti-androgens part also and finish it. So the main drugs which we usually use are the spironolactone. The main mode of action is they decrease they compete at the receptor level. So with the androgens, and they also help in binding a little part of action even on binding the free androgen to the sex hormone binding of. So it most commonly uses the spironolactone. It is an aldosterone antagonist. So we are very worried about her electrolytes. We monitor her electrolytes. And within 3 weeks, we can see a drastic decrease in her androgens. Then within a 3 months period, we can see that there is a little decrease in her facial. The acne are also improved. And then it takes a 6 months period time for actual hirsutism to come down. And the other drugs are cyproterone acetate and finasteride and flutamide. Cyproterone acetate, cyproterone acetate is used, the mode of action is similar, and it is has a high progesterone component in it. So it decreases the LH release and also acts at the binding level. And we can give it along with estradiol, which helps in when you combine it with ethinyl estradiol, the effect is excellent. Thank you.
Thank you, ma'am. Thank you so much. So, two very important points Dr. Madhuri has highlighted. A, first of all, OCPs are perfectly safe, and in fact, at many times, very, very important to control the other symptoms. And contrary to the belief that a lot of Indians have, they really don't have that many side effects, especially in our patient who is a teenage. The side effects start happening more after 35, the metabolic side effects and all the other liver side effects. They are more for the people who are more than 35. But then again, these are very, very important. And the second point is, no matter what medication we are giving, because of this life cycle of the hair, anything that we are going to give will have a effect only after, the proper effect will only be seen after 6 months. And that's why my last question is to Dr. Sai Krishna. For these initial 6 months, what are the local treatment options that are available to the patient? And what is the youngest age at which the laser is safe? And how often does it need to be done? What are the factors that make the response poor?
Yeah, thank you. Thank you for this opportunity. And the previous speakers have elaborated very nicely about this particular case. So Dr. Rajita has also given a beautiful perspective of a dermatologist's concern in these particular cases and how to deal with them. So from my side, when we are coming about these local treatments, of course, because of their safety, they can be taken as. Hello, am I audible?
Yes, ma'am. Yes, sir, you're audible, sir.
Yeah, so the thing is, according to for their safety purpose, it is a best one of the best options to be started. But here, two case scenarios are there because this is a baby. Because when I see a prescription of this age group coming, they have written baby, so and so. So we are dealing with a very new girl who has just attained menarche and then her cycles are irregular. It is already traumatizing to the family and with all these things. So the counseling part becomes very important. And there are two scenarios where the patient is approached the dermatologist as the first, and then the second scenario where the patient has already visited the gynecologist and endocrinologist first. So if it is a dermatologist where the patient is coming first, then I had to explain all the conditions, and I would definitely take the help of our endocrinology and gynecology colleagues to identify, because I work in a multi-specialty unit, so I have an extreme beautiful team, and they support me very well. When the patient is coming after the treatment, say after the treatment, she has been started on OC pills and all these things, then I would wait for the effect of these medicines to start. So meanwhile, simple techniques like bleaching, shaving, and simple waxing, small things can be done for hirsutism part. Once the hormones are stabilized or when the medicines start taking their effect, then probably I would like to introduce laser. See, here again, it is controversial because the child is slightly age is less than 15 years. So it's not totally contraindicated. But here again, the skin of the patient, the Fitzpatrick type, we call it, the darker skin, lighter skin, and the coarseness of the hair, all these determine the results of the patient. So if the patient is having very fine hair, even though she is having more, but comparatively fine her hair, I think the results of these lasers would be very not that good. So the realistic expectation to the patient has to be explained. And if there are significant hair and it is causing significant problem for the patient, yes, we can, with the proper counseling and parental consent, we can go for the laser therapy. Otherwise, even the eflornithine cream also can be used. Though it is not a very great drug, but it definitely reduces the hair length and the speed of hair growth, and of course the mass. But already saying this, we are coming across recently I had a patient who had already gone for laser therapy and all these things at places what we can call them as quacks, because just they are owning a machine and they are opening a clinic. They are starting without analyzing the patient, and without this, nowadays this has become a fashion of doing laser. So I think we require all the other departments also to understand that these kind of malpractices are also happening. So once the patient is started and is on patient is responding well to the OC pills, then we can add the laser if required. That is, hope it's clear. Thank you.
Thank you, sir, for highlighting probably the most important point before we go on to the next case, that adolescent PCOS has to be ideally handled in a multidisciplinary team, and each of the three main arms, gynecology, dermatology, and endocrinology, have their role to play. And as you rightly said, to prevent the patient getting maltreated somewhere, who are probably not trained in that aspect, not just laser, but even a lot of these times, a lot of people who don't really understand PCOS giving medication. So to prevent all of that, it's very, very important that all of us come together and manage this patient. And so far, thank you all for listening. Moving on to the next session.
Thank you a lot, Dr. Khushbu and all the panelists. I think it was a fantastic opening to our endeavor in a multi-speciality approach to PCOS. Rolling start by the Telangana team and the endocrinologists on board. I think it's great. So for the next session, we would invite Dr. Jayanti Reddy to actually introduce the topic. But before that, I'll just introduce the panelists. For the panelists for the second session, the topic is going to be 23-year-old girl with severe jawline acne who's planning pregnancy. The panelists are Dr. Maithili. She's a consultant endocrinologist from Visakhapatnam. Dr. Chitra Selvan is not with us today because there has been a health issue in the family. So yeah, Dr. Maithili will take her questions. I can also chip in. Dr. Shravanti, she's a laparoscopic and robotic surgeon. She's from Shravanti Hospital in Sainik Puri, Secunderabad. Dr. Vandana Hegide, who is the Clinical Director and Chief of IVF Consultant, Hegide Fertility, Hyderabad. Dr. Ashwini Guttedar, who is a Senior Dermatologist from Dr. Ashwini's Derma Care in Hannamkonda. And Dr. V. Anand Kumar, who's a hair transplant surgeon from KIMS Hospital. And the moderator is going to be Dr. Kashish Gupta, who is a consultant endocrinologist from the PSRI Hospital in Saket, Delhi. So I'd invite Dr. Jayanti Reddy to please introduce this topic and then take on the proceedings.
Yes. Thank you, Dr. Santosh. And it's a great opening, as I said. And this is the age groups, but it is something of a lifelong problem, starting from the adolescence. And the same adolescent girl, we take them into after marriage, and then they into the reproductive age group, where they will be facing the problem of getting pregnant, and also the problem of continuing with that pregnancy and having the problems associated with the pregnancy. And later on also, they're the same people. We have had the opportunity to see these girls right from adolescence till hysterectomy and also into the menopause. And the same girl will again in the reproductive age group in the later end may come with heavy menstrual bleeding and abnormal uterine bleeding, and also may land up with our histoscopy and hysterectomy. So therefore, now what we are facing out, I think those are topics for another day. But for today, there is this girl who the earlier panelists have managed her, and then she married, and now she wants to get pregnant, and she is having a lot of acne. Not only this, but we see patients who go through IVF and then come, and we have to know how difficult it is for them to get pregnant, how difficult it is for them to keep the pregnancy, and all the complications. We have a wonderful panel with us, and also I am honored to see Dr. Kashish Gupta here from PSRI Hospital, Saket, Delhi, who is going to conduct this this panel. Over to you, Dr. Kashish, for the panel discussion.
Thank you so much, ma'am and sir, for the kind introduction. I would like to thank Endocrine Society of India for giving me the platform to moderate this session. So without further ado, I would introduce the second case to you all. So we have a 23-year-old lady with us who was married 1 year back, and she's planning pregnancy in the next 6 to 8 months. And she's come to us with the chief complaints of severe jawline acne, which she notices that they flare up premenstrually. Her menarche started at 13 years of age. She has regular cycles, but with the last 3 years, she has noticed that her menses duration of bleeding has reduced from 7 days to around 2 to 3 days. And she has also noticed a gradual weight gain of around 8 to 10 kgs in the past year. She does not complain of any abnormal or excessive facial or body hair. On examination, this lady has a BMI of 26 and a blood pressure of 136 by 86 millimeter of mercury. We have nodulocystic acne on jawline with acne scarring and hyperpigmentation. She has acanthosis nigricans of grade 2 and a modified FG score of 6. So I would like to direct my first question to Dr. Maithili ma'am. Ma'am, as an endocrinologist, how would you approach this patient with jawline acne and planning pregnancy soon?
Yes, Dr. Maithili ma'am, we are not able to hear you at all. No, not at all audible, ma'am. Dr. Kashish, can you take the next question and then come back to Dr. Maithili so that she'll just sort out what's happening?
Sure, sir.
Yeah.
So I would like to go to Dr. Vandana, ma'am. Ma'am, as an obstetrician, how would you approach the preconception counseling in a woman with severe acne, especially when she's not been evaluated for hormonal or fertility issues?
Yes. Till the last case, I think we were having confusion with respect to the diagnosis because we're unable to do an ultrasound scan. Because now, since she's, being 23 years, now, right, with this age, I think our Rotterdam criteria is very important because most importantly, we should know, is she a PCO? Because that is the main thing that we need to rule out, especially when a girl comes with acne, because here there is androgen excess, and going by the history that she does have regular cycles. So with hypomenorrhea, now hypomenorrhea can also present with hyperandrogenism. And here, as a obstetrician and gynecologist, we have a patient here who's planning pregnancy also. So we need to look at her fertility options. So now the question comes: is she ovulating? So whether is she anovulatory or she's probably ovulating with regular cycles also. So in this case, I would tell that going by her. Hello.
Yes, ma'am.
Yeah. So as we stick to Rotterdam criteria for diagnosis, we need at least 2 out of the 3 criteria positive, where it should be either oligoanovulation or biochemical or clinical hyperandrogenism, or there should be an ultrasound diagnosis of PCO. So I would start with doing an ultrasound scan of PCO. Hello. Yeah. Where she is married now. So we definitely have an opportunity to do transvaginal scan, which is very important to be able to be diagnosed based on the follicle number seen in her each ovary. So even the standard scan machines that we have today with a good resolution, we stick to a diagnosis of PCO when we see more than 12 antral follicles in either of the ovary, right ovary or left ovary. And if the antral follicle count is high and she's having regular cycles, then I would also want to check her serum progesterone, because just to know whether she's ovulating. So day 21 serum progesterone, if it is more than 3 nanogram per ml, would suggest ovulation. Anything less than 3 suggests anovulation. So with this criteria of her severe acne that she has with probably anovulatory cycle, ultrasound diagnosis of PCO, we diagnose her as a PCO first. Now with this, now we have a history of weight gain, and we also have our BP being borderline. So all this also tells that there could be some amount of metabolic syndrome in her. So and since it's our first consultation, I think we need to give her, as Dr. Jayanti madam pointed out, that PCO is not just something related to fertility problem or just not dermatology, because at the end of the day, we always need to understand that it is a chronic inflammation, it is a metabolic syndrome. So we need to sit and explain her what is PCO. We need to explain her that this disease is going to be, probably progressing through her reproductive phase until the age of menopause. So we need to explain her the metabolic risks involved over here. What are the problems that she can encounter? It's not just, acne. It's about her fertility problems, what she may encounter, her need for treatments to assist her, fertility, conception, and then the risk during pregnancy, whether it is risk of gestational diabetes, preeclampsia, and also the weight gain related issues where there may be, predisposition to cardiovascular disease, including ischemic heart disease, myocardial infarction, stroke. So they will have even risk of endometrial cancers in future. So we need to stress the importance of, follow up, whether, because we may not get her again to be able to counsel all this. So at the first consultation, getting a diagnosis of PCO that is confirmed, and then, explain her the disease progression and all the required follow-ups that is required, because since her BP is high, we need to confirm her lipid profile at this stage. It's better to do a fasting lipid profile. It is also important to do an OGTT at the first visit with her HbA1c, as there is a history of weight gain. So with all this, we get her baseline parameters of PCO. And since she's also worried about acne and she's just 23 with a short married life, her getting pregnant may not be that important right now. So what is important is what she thinks is important. If she thinks her acne is a problem, and if her ovaries are showing good amount of egg reserve, there is no emergency to get her pregnant. We can always, take care of all her hormonal evaluation, and based on what her, dermatologist feels, if she needs any specific treatment for her acne, she can definitely pursue. And probably if she's postponing her, treatment for pregnancy, for the acne, we should be very careful in this girl, because we cannot use, contraceptive pills, because she's already gaining weight. She is hypertensive borderline, and we don't know really how her sugars and lipid profile are going to turn out. So there is a risk of, thromboembolism with contraceptive pills. So ideally, we need to use very low dose OCPs in these women of PCO. So we need to be careful, because the OCP may give an added advantage of decreasing androgens, to help the dermatologist during that treatment. But we need to be careful in this particular case, and probably keep her monitored. And when she finishes her acne treatment, she can come back, and then probably with, lifestyle modification and all this, if there is no significant weight loss, or if she doesn't get pregnant with lifestyle modification, then I would definitely consider ovulation induction and follicular tracking with a timed intercourse as the initial step in her fertility treatment.
Thank you so much, ma'am, for sharing your insights with us. Dr. Maithili, ma'am, I hope you're audible now. So
Yeah,
my question, yes, ma'am.
Thank you. Sorry for the disturbance.
So, ma'am, I'll repeat your question. As an endocrinologist, how would you approach this patient who has come with jawline acne and planning pregnancy soon? What kind of hormonal evaluation would you go for?
Yeah. So, as has been mentioned by the earlier speaker, so this lady, young lady, has, she's overweight, she has acanthosis, she has hirsutism, she has a hormonal acne, as has been mentioned by the earlier speakers. And then she also has a slight elevation of blood pressure. So the diagnosis definitely that needs to be considered is a polycystic ovarian syndrome after exclusion of other endocrinopathies. So the workup we do in this particular patient is to rule out other endocrinopathies. We do a T4-TSH assessment, then a serum prolactin to rule out hyperprolactinemia, and a basal 17 hydroxy progesterone in the follicular phase to rule out a non-classic CAH. And then, of course, as Dr. Vandana mentioned, assessing her metabolic health is of paramount importance. So do an A1C, then look for MASLD, then her lipids, and also her lifestyle issues like mood disorders, eating disorders, if any, need to be addressed. Now, at this point, what I would like to advise this young woman is to have a healthy lifestyle, emphasize on weight reduction, which really matters to have a natural conception. And then also, if she's planning to use medications for acne, like anti-androgens or hormone therapy or some of the dermatological treatment modalities also may not be safe for pregnancy. So we need to emphasize on the safety issues of these particular medications.
Thank you so much, ma'am. Next question is to Dr. Ashwini. What acne treatments do you absolutely avoid in patients who are actively trying to conceive? And how early do you stop them before pregnancy? This is a very important question. Most of the patients are taking a lot of medications that they may need to stop before trying to conceive. So what are these medicines? Dr. Ashwin?
Yeah. Now that can you answer the question yourself?
Okay. So,
Yeah.
so basically, this question was asked from a dermatologist's point of view. What kind of acne treatments they would want to stop
Rajita?
before.
Yeah,
Rajita,
hello, hello. I'm audible?
Yeah,
Hello.
sure. Ma'am has come.
I'm audible?
Yeah,
Yes, yes.
Yes, ma'am.
Yeah, yeah. So I could now when the patient such type of patients arrive to me, first the most important thing for me is the counseling. I'll consult the patient first, ki whether she has to for her conceiving is more important or taking an acne treatment is more important. So after counseling her properly, if she says, "No, madam, for me, for getting me, I want to become pregnant, so that is more important." So here my treatment line changes. If she says, "No, for me the pregnancy is most important," mostly I will stick the treatment like plain clindamycin, topical creams like clindamycin I give her. Here the acne is very severe, so I have to start her on oral antibiotics also. So I will restrict to antibiotics which are safer if she get pregnant also. So topically, mostly I will give her a clindamycin, and orally I can go her for erythromycin or cephaloxime or any other antibiotic. I will also plan her if she is ready for getting some chemical peelings done. I will suggest her to get a peel done because she has a very severe jawline acne. And during counseling, for me, the lifestyle modification is more important. So counseling is more important. Her diet, exercise, sleep patterns are very important because this really we can reverse the hormonal changes what she's getting. Because here I can see all the signs that are all red flag signs like jawline acne, weight gain, oligomenorrhea. She's somewhat overweight. Her BMI is in between. It will come in overweight. She has grade 2 acanthosis. So this all slowly she's from her menarche. She's slowly shifting toward the hormone changes what she is getting. So for me, most important is counseling regarding her sleep patterns, her diet, her exercise. So that will really help her to reverse it. If she is planning for pregnancy, if she is not planning of pregnancy, the plan of treatment will be different because being a scarring acne she has, I can plan for a topical tretinoin or isotretinoin if she is not planning for a pregnancy. So my treatment plan changes depending upon what the patient wants, whether she has to get pregnant in next 6 to 7, 8 months, or if she doesn't want to get. If she want to get a pregnant, then I will be very conservative. I will not use drugs like tretinoin, adapalene, or isotretinoin because tretinoin itself is a category C drug and isotretinoin itself is a teratogenic drug. So this everything I have to make her, sit her, and explain her.
Okay. Thank you so much, ma'am. I've definitely learned a few things.
Yeah.
If Dr. Santosh, sir, if you could just help us with this next question. If the hormonal evaluation of this patient reveals PCOS or insulin resistance, how would you want to manage it, particularly in the context of acne and upcoming pregnancy?
Yeah, so I think I will take the cue from Dr. Ashwini. She has said a very good thing. So whenever such a patient comes to me, I tell them to take at least one day to decide what is important for them. Is acne treatment more important for them, or is pregnancy more important for them? And I always would like to involve the husband in the decision also, because there are a lot of familial pressures that come from all at this age, either from the in-laws and from the parents, etc. So the husband has to be very supportive of whatever decision the wife takes. If they have decided that acne treatment has to take precedence now, I would approach it the similar way with diet, with exercise, and with OCPs and aldactone, so that her acne part is taken carefully. And we have to be very careful in counseling that a short course of OCP is not going to harm her long-term fertility levels. But yes, very not very surprisingly, 50% of the couples will come back and say, acne at the moment is not very important for us. As an endocrinologist, please treat us for the pregnancy. In that case, yes, metformin seems to be the best bet over here. Metformin is known to rapidly improve fertility levels and ovulation levels in people with PCOS when combined with good diet, both aerobic and strength training exercises, and a little bit of mind relaxation techniques. If you're able to take metformin, you will conceive earlier. So I would prefer to take metformin, to give metformin, and also refer to my dermatological colleagues who would like to treat them with the treatments for the acne directly without giving any contraceptive pills.
Thank you so much, sir. The next question is for Dr. Shravanti. Ma'am, if the patient was recently on OCPs, as you must be getting a lot of patients who will be coming with oral contraceptive pill usage, and now she wants to conceive, how soon after stopping them would you recommend trying for pregnancy, and would you be monitoring ovulation status right away?
Hello, good evening. Kashish, are you able to hear?
Yes, ma'am.
Yeah. Thank you for the opportunity. And as already previous speakers were telling, see if we don't know about the marital life and how seriously she is planning for pregnancy. If it's really planning seriously for the pregnancy, we have to give the importance because already she is using OC pills. We have to take the advantage of that because OC pills already have that. We have taken the control of the cycle now because of the PCOD, there will be irregularity and hypomenorrhea. 3 months or 6 months, whatever OC pills she was using, that will be corrected and the cycle will be in under control. And also OC pills will do, because of previous treatment, it decreases the high LH levels. Because of that, it can be a detrimental to the egg quality and easy to the embryo development also. And also we are, as you have suppressed the ovaries, large number of healthy follicles are recruited now, right now. And development of egg retrieval also very easy. So I will definitely use this opportunity and immediately I'll go for the induction. It may be after seeing the AMH, or I will exclude other any infertility causes and I will see the even husband causes before going into the stimulations, all that. I will evaluate and give counseling, couple counseling and family counseling, and I'll explain the importance of the pregnancy right now because she is seriously saying into the pregnancies. And definitely I'll go for the primary like a clomiphene, or if she is not responding, definitely I'll go to the gonadotropin, all that. Because after OCPs, it will be easy to get pregnancy within 6 months to 1 year. So definitely we have to use this opportunity after proper OCP usage.
Thank you, ma'am. So I would just like to add one small question. What kind of OCP do you think you start patients on? Like, is the cyproterone acetate component something that bothers you and you would want to stop it earlier or not?
Ashish, you're asking me or Santosh sir?
Yes, ma'am. Yes, ma'am. I'm asking you.
Yeah, I
yes,
want to stop because cyproterone I don't want. Better to be with simple OCPs, 30 milligrams estrogen and.
Okay. Thank you. So the next question is for Dr. Anand, sir. So if patients planning for pregnancy, what kind of topical agents or procedures do you consider safe for active acne, hyperpigmentation, and scarring? Because a lot of patients, before they're trying to conceive, they would want to know if laser is safe or any chemical peels are safe. And what is the safe period before conception to use these agents?
So if she is planning for pregnancy immediately, then this like topical antibiotics like clindamycin is safe. Along with the clindamycin, we will give benzoyl peroxide also, and these two agents will prescribe throughout the pregnancy. Also, it is safe because sometimes in pregnancy also this acne may be aggravated. So to control that, we will combine the both clindamycin and benzoyl peroxide. Also, benzoyl peroxide we use depending upon the 2.5 to 5% 5% strength. And sometimes the pigmentation is there. We'll to control the acne and also to the pigmentation. We will prescribe topical azelaic acid also. Topical azelaic acid like strength is 10% to 20%. It is also safe throughout the pregnancy. Also they can use it. So to reduce that pigmentation, some niacinamide also it will help in reducing the pigmentation, and vitamin C also it will help. So glycolic acid we will use for limited strength like 10%. Azelaic acid is also we use for limited area only, not because sometimes in the pregnancy its absorption is more, this causes problems. So limited area we can use it for to control the pimples. If she's planning for pregnancy for like say 6 to 8 months, then we can use everything like topical retinoids also we can use it, but we can stop just before 1 month before planning for pregnancy, because topical retinoids in pregnancy it is again is a, though despite there is a potential, but there is a conflicting data is there on topical retinite, but systemical retinite like isotretinoin is definitely is contraindicated. That can also we can stop 1 month before planning the pregnancy. But topical retinoids like adapalene, generally we prefer the topical retinite for most of the cases. But in this scenario, there is a despite there is a potential is there, but conflicting data is there. I will just better to avoid it. I will avoid it. Then I will prefer the only benzyl peroxide. And comes to the procedures, generally if she is planning for the pregnancy, I will usually avoid for the all the procedures, either the chemical peel or lasers. But despite there is a data on like low strength chemical peel like glycolic acid peel or salicylic acid peel for low small areas can be done. But usually for all the lasers and chemical peels, if she is planning for pregnancy, I usually avoid it.
Thank you so much, sir. Dr. Maithili, ma'am, in this patient's hormonal evaluation, you have told us most of the things, but when would you specifically consider suspect a non-classical congenital adrenal hyperplasia in patients like these? And would you evaluate adrenal function normally in these patients?
Yeah. So ideally, an evaluation for non-classic CAH by doing the basal 17-hydroxyprogesterone estimation in the follicular phase, especially if the woman is menstruating regularly, is the choice. It is ideally, yes, you have to do in all cases of PCOS to rule out a non-classic CAH. And then, however, in this particular case, the evidence that this is PCOS is so strong. She has insulin resistance. She was having regular cycles till last 1 year. I think it can be an optional test. But then when do you consider a non-classic CAH or the indications for testing that? Number one, a girl with premature puberty, and then an adolescent peripubertal with hirsutism, acne, oligomenorrhea, an adult with infertility, and sometimes even asymptomatic also. So these are all the different scenarios where one needs to rule out non-classic CAH.
Thank you so much, ma'am. Dr. Vandana, ma'am, in women presenting with severe acne who are planning pregnancy, what sort of fertility challenges do you most often anticipate, and how early do you want to address fertility challenges? How long are you willing to wait before you start fertility management for these patients? Dr. Vandana?
Hello.
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Hello, can I hear the question again?
So, ma'am, the question is, yes, ma'am. The question is that in a woman who is planning pregnancy, she's presenting with severe acne. What sort of fertility challenges do you most often anticipate? And how early do you want to address these fertility challenges? Like, how long are you willing to wait before you intervene for, say, ovulation induction?
Yeah. See, the fertility issues, it always depends upon the choice of the couple, what exactly they want. I think that is something very important we need to consider. And then coming to the diagnosis of fertility. So one thing about ultrasound scan, I just want to, make it very clear, because today we have got a multidisciplinary team on this platform today. We've got dermatologist and endocrinologist. Now, as a fertility specialist, I do my own scan. So, and we do the transvaginal scan on our own. So we are very sure about the diagnosis of PCO. But we have seen many patients, who come with their abdominal scan report, who are under treatment with a dermatologist or endocrinologist, where on abdominal scan, they've been diagnosed PCO. So this is something that we need to take care, because many times these women, actually, because we cannot see the follicles, on abdominal scan. So we always go wrong in the number of antral follicle count. And if we have taken a diagnosis based on that, we can go wrong, because many patients of these could be decreased ovarian reserve. That's something we see very constantly, where they actually have very less number of follicles when we do the scan, and then they actually have a very low AMH. Now, AMH cannot be used presently, at least, we have still studies coming out whether we can use AMH to diagnose PCO, because we all understood by this discussion that FSH, LH, we are not doing so many testosterone, because so all hormones, they can vary month on month, but AMH is something that is very constant. So at least for a time being, I think we can still do an AMH and see if values are quite high, because as dermatologists and endocrinologists, when you don't do the scan yourself and you are not sure about the diagnosis, I would suggest you can use AMH, where definitely 3 to 5 is normal. Anything more than 5 or 6, you can put it under PCO. Anything less than 3, they should be very careful that it could be a decreased ovarian reserve, because again, we know that hyperandrogenism again comes back in menopause. So there are women with very low AMH, like 0.2, 0.3. They also have, again, they're back to acne, hirsutism. So this is something that I would take care that by diagnosing her ovarian reserve, I'll take a call whether, at least from my side, do I want her to get pregnant fast? Because if decreasing ovarian reserve is there, we need to hurry up with her pregnancy and look for other factors. Is her tubes open? Any tubal block is there? Any male factor is there? Is there any real indication that fertility treatment has to be done immediately? If not, then definitely it is her choice. We can give her some time to control her acne, because as dermatologists have told us today that physical appearance today and so many things matter for her psychological balance. And looking at this, definitely it's her choice regarding fertility. But wherever I feel it's medically indicated, I'll definitely counsel her for an earlier completion of her family.
Thank you so much, ma'am, for clearing the air about AMH. That was very important.
Sure. Thank you.
And yes, Dr. Ashwini, ma'am, I would like to ask you, in your experience, does hormonal acne usually improve or worsen during pregnancy? And what are the sort of red flag signs that prompt you to suspect that this is indeed hormonal acne?
Red flag signs in this case is she is getting more acne over the jawline, her weight gain. So the menarche was proper, but once slowly she progressed to her adolescence, she's getting more of the acne over the jawline, weight gain, reduction in the menstrual duration. Her BMI is slightly in between. She comes in overweight. So acanthosis is there, grade 2. So these are all the red flag signs which, so the patient is slowly landing into the hormonal acne. Might be this will be for her difficult to conceive also. So for me, in this case, the most important is lifestyle modification. Her what are her daily routines? I have to change her daily routine. I have to change her diet. I should more pressurize on her exercise, all the strength training exercise, aerobic exercise, whatever she can do. So this red flag sign will be reduced. Then slowly, if she, then the same thing what I told you, whether for her pregnancy is important or looking good or treating acne is important, because her acne is scarring here. Because once the acne is scarring, if you don't treat in the time, that will be problematic in future, because the scar will be anyhow, any treatment we do, it is difficult to reduce the scarring. So here the patient counseling is very important, and what type of treatment she want and what she's planning. And many times what I have seen, the patient first they come to dermatologist when they have severe jawline acne. When still we explain them that this is because of the hormone changes, but they don't accept it. You are getting so many treatments, but I'm not getting a reduction in this jawline acne, because these are a difficult case. If you refer them to a gynecologist, endocrinologist, they will not be happy. So for us, such patients are very difficult to treat. So for us, initially is more of counseling and changing their diet and changing their all the lifestyle, their routine. So here we have to consider everything while treating such patient.
Thank you so much, ma'am. And very true, these patients always land up in dermatology OPD first, and then they get referred to an endocrinologist or a gynecologist. Dr. Shravanti, ma'am, if this patient conceives while still on acne medications, which sort of drugs or procedures would you be worried about in early pregnancy, and how would you want to counsel or manage this patient now?
Yeah, as already told our dermatologist, so isotretinoids or oral, it's a very dangerous because teratogenic. And also, somebody are messaging like topical, we can use retinoids, but still, as a obstetricians, we are like even the smallest risk also we don't want to take actually. So topical also we will not advise, and of course, spironolactone. Definitely, we don't want to take. And other things like thalidomide used to be like treated previously by the dermatologist, now not in regular use. So these three are like my concern. So if they are really taking long term, then I'll counsel about the teratogenicity and the possibility of defects before planning. Then only we'll proceed for the pregnancy. That definitely that will be again the couple counseling we have to take.
Okay. Thank you so much, ma'am. And the last question is for Dr. Anand, sir. So in your practice, when you normally get a patient who has acne and has severe acne, how often do you see these patients to have acne severity correlating with metabolic factors like obesity or insulin resistance? And how does that change your treatment choices? What is your sort of threshold for recommending or referring these patients to an endocrinologist or a gynecologist?
Yes, definitely acne severity can correlate with metabolic risk factors like obesity, insulin resistance. So especially in the adult female patients, even in these patients, she has a jawline acne and also she has acanthosis nigricans grade 2. And jawline acne, these two are, and modified FG score is 6 also. All these 6 hyperandrogenism features is also there. Because see the insulin resistance, they definitely they stimulate the it increases insulin and also IGF-1, which indirectly stimulate the sebaceous gland activity. So that is indirectly, though acne also will increase in case of insulin resistance. And also insulin resistance, it will increase androgen production also. So all these things will cause the keratocyte proliferation and comedones formation. So they keep on going acne. So acne severity also definitely will increase in case of metabolic risk factors. And obesity, in obesity also there is a halted hormone metabolism will be there. There is increased free androgen levels. So that can also indirectly will increase the acne formation. So definitely there is a metabolic risk factors will definitely increase the severity of the acne. In such cases, definitely first the lifestyle modification is more important before treating the acne. Diet modification like low glycemic index diet, and you have to tackle with the insulin resistance also. For this, they usually I will refer to the endocrinologist also. I will definitely I will refer with endocrinologist, and along with the endocrinologist, then I will treat the acne.
Okay. Thank you so much, sir. And I think we can agree that we've had a wonderful discussion. So over to Santosh.
Kashish, sorry to disturb you. I'm Dr. Shravanti. One more thing is antibiotic. Forgot to tell about antibiotic. So tetracyclines, usually dermatologists will give tetracyclines for this
Yes.
antibiotic. So that also we have to take care. So anything classification, we have to avoid those drugs also.
Usually, we will avoid tetracyclines, madam. Suppose she is planning for pregnancy.
Yes.
Generally, we will prescribe doxycycline or minocycline. Yes, but we will avoid if she is planning for pregnancy. Then in
Yes, sir.
such cases, we will prefer azithromycin. Azithromycin is safe. And
Yes, sir.
even
Yes, sir.
erythromycin is also not that useful in case of acne.
Perfect.
So we prefer azithromycin, erythromycin if she
Yes,
is
sir.
planning for pregnancy.
Perfect. So over to Dr. Santosh, sir.
I think Dr. Jayanti and Dr. Darak, would you want to just summarize today's program in one minute? Dr. Darak?
Yeah, it's a very, very good program, sir. So the multi-specialty approach is very good in organizing such webinars in future. This will help a lot in controversies and better treatment for the patient's benefit also, for us beneficial to everybody, doctor and patient. So this is a very good approach to have things in future also. Thank you very much, sir.
Thank you, sir. Dr. Jayanti, are you there, ma'am? Right. So I think we'll close the session by giving a vote of thanks to each and every person who has come today, taken out time from their busy practice, and has been there for the initial multi-speciality approach to PCOS panel. I think overall it was a great success. We have learned so much from all of each other, and I hope all the younger dermatologists, gynecologists, endocrinologists, and dermatologists who are all taking care of PCOS have also imbibed a lot of knowledge from the experts who are here. Dr. Jayanti is here. Ma'am, would you also like to summarize this program in 1 minute and then we'll close?
Yes. Dr. Santosh, it has been a great experience, going through all the cases and the discussions were par excellence. and also that point that which we have told that giving oral contraceptive pills without with a higher dose, because we have 35 micrograms of this is ethinyl estradiol. We are seeing cases of DBT and also cerebral thrombosis in the young girls. So you have to make sure that a low dose has to be given for them, and also the importance of see, initially we were always telling, we were blaming them for their weight and all, but we have to understand there is one aspect of the environment also. We have xenoestrogens, we have all these estrogens which are there from all the pollutants. So we have the endocrine disruptors also which are there in our things. So sometimes we feel sorry now for our adolescents because of their exposure and also, of course, their lifestyle. All these things put together, we have now an overview of all these. And also, when we are prescribing, we have to be a little careful, especially these young girls, that if you're giving retinol and all, again, if they get pregnant, we'll have to terminate the pregnancy. So these are the two pertinent points in the adolescent age group, as well as in the those individuals who are planning for pregnancy. And all the points have been brought out from the diagnosis till the treatment. And I thank all the panelists and thank all of you and all the societies for being here. And good night to all of you.
Good night. Good night. Good night, all of you. Thanks a lot.
Thank you. Thank you, sir.
Good night. Good night.
Thank you.